Good evening, ladies and gentlemen, and welcome to Valley Public Radio. My name is Joe Moore. I'm the Director of Program Content at the station, and we welcome you to the Barman Cheney Performance Studio today for this Be Public Live event. We're thrilled to have all of you here. This is only the second one of these forums that we've had here in our new broadcast center in this new series, so we're really excited to have such a good turnout for this topic, which we've had a lot of feedback on. Before we get started, just a few housekeeping notes. You're welcome to keep your mobile devices out there and tweet and do all that, but if you could please make sure they are silent, because while we're not broadcasting this live, we are recording this, and it will be available later on our website as a video and an audio recording. Also, we want to thank our partners who help make all of what we do in our news programming possible. Of course, our members here at Valley Public Radio, being a member-supported radio station, they do the bulk of the work that keeps our operation going. Also, specifically, our grant partners that fund our news team, the California Endowment, the California Healthcare Foundation, and the James Irvine Foundation, who their generosity has helped us really build our news programming here at Valley Public Radio. And I want, before we start, and I introduce Kerry, Klein, who's moderating this event, I want to recognize our other staff members who are here tonight. We have Ezra David Romero, one of our reporters here, manning the camera, and also Jeffrey Hess. Where is Jeffrey? He is in the studio back there with Don Weaver. So without further ado, I will turn it over to reporter Kerry Klein, and let's begin this Be Public Live event. Okay, thanks, Joe.
So I'm Kerry Klein. I'm our health reporter here at Valley Public Radio. I echo Joe's thanks for all of you for being here. I am galvanized by how enthusiastic our response was to this event. This is clearly something that people are really passionate about, and so I'm excited to talk about it with these panelists. And so this is part of an ongoing project that I'm working on to really pick apart this doctor shortage here locally. It'll culminate in a series of stories that will run in July and August, which may feature excerpts from this discussion as well as many other interviews with stakeholders in this issue. And it's also being supported with a grant from the Center for Health Journalism at USC. They foster a lot of health reporting that's out there. So my goal tonight is to really shed some light on why we have this problem, why it's a local issue, what makes us different from other parts of California, and also what could be done about it and what is being done about it. So most people here, I think, are affiliated in some way with the healthcare industry, but I hope that we're able to dig deep enough that we can all get something out of this discussion. So the plan is for us to have a guided discussion for about 45 minutes, and we'll leave the last 15 for audience questions. So hang on to anything that you want to ask for later. I think let's get started. So the panelists sitting in front of you, we have Dr. Michael Peterson. He's Associate Dean and Chief of Medicine at UCSF Fresno. Dr. Sanjay Srivatsa is a cardiologist and the Physician Director of the Heart, Artery, and Vein Center of Fresno, and Jason Bailey, the Deputy Chief of Operations and Workforce Development, essentially a recruiter for Clinica Sierra Vista. So welcome to each of you. Thank you for being here. So I think for the first question, I think at the highest level, this problem is described through numbers. That's kind of how we refer to it. Various medical groups prescribe a certain number of providers per unit population. And here in the Valley, we're significantly below the recommended supply of primary care physicians, specialists, nurse practitioners. We're the second lowest region in the state for all of these providers. And for comparison, the highest is the Bay Area, which has literally twice as many doctors, twice as many providers per population that we have here. But are these numbers really the whole story? So I'd like to ask each of you to share how you experience the doctor shortage in your own work. Let's start with Dr. Peterson.
So thank you very much. I'm pleased to be here and discuss this issue that is core of why UCSF Fresno actually exists here. And I think that a couple of object lessons that really demonstrate the physician shortage. One is that we run clinics for primarily the Medi-Cal population on the teaching campus of CRMC that has some of the only subspecialists who will provide care for Medi-Cal patients. And we know that we have waiting times as long as 1 year for patients to get into some of those kinds of services just because the physician numbers aren't there and the patient demand is so high. The second thing I think that we experience on a daily basis is an overcrowded emergency department, in part because patients can't access primary care, but then it couples with the fact that those patients, when they do get admitted to the hospital, end up having to stay longer in the hospital because they can't get primary care follow-up, or simple problems that might be able to be handled because a primary care doctor could see the patient in a day or two in the emergency room. They don't have access to the primary care, so those patients end up being admitted to the hospital. And all of this impacts the care and impacts the patient volumes in the hospital. So I think from our perspective, those are a daily occurrence for us.
And yeah, would either of you like to share your own experience?
So I can tell you from my perspective, some of the statistics that are out there right now, for example, like with family medicine physicians just coming out of residency, generally they say there's about 3,000 plus job opportunities open for each graduate at time of graduation. So it is an extremely competitive process. It's just that there are so many jobs for a lot of these folks that it's challenging and difficult to bring them in, for sure.
And Dr. Srivatsa, you're at a private clinic, perhaps. Do you, when patients come to you, how do you sort of experience? Is there a long wait time at your own clinic for patients, or do they come to you complaining of other experiences they've had elsewhere?
So my wait time is about 2 months currently, but I agree entirely with what Dr. Peterson just told you, and that is that there is an unfair burden placed on people downtown at the UCSF campus and throughout community regional medical centers to absorb the burden of lack of sufficient primary care and specialist care in this community. I've had a chance to see care on both sides of the Atlantic. I trained and grew up in the British National Health System, and it was, when I left there, commonplace to complain about waiting times for hip replacements and such like. But there wasn't anybody saying nobody could go to a general practitioner or didn't have access to any kind of insurance to be treated for common maladies. On the other hand, and I'm not an expert on the deficiency of primary care providers. I think it's self-evident. The numbers are there. Dr. Arambola's bill was aimed at generating more of the primary care physicians that are required in order to service these people, whether we do it with primary care doctors, whether we do it with specialists, whether we do it with mid-level providers. That's all well and good, but at some point in the system, as a specialist, I feel that we have to also come together and put our backs into servicing this population. Unfortunately, if you look around, it isn't just a dearth of specialists, it's a dearth of specialists willing to accept this population. I think I'm speaking very plainly because most of us who are here who ever tried to get a specialist to treat them and have that kind of insurance know very well what the problems are. It isn't any one person's problem, but there is a global problem in the coordination of, let's say, Medi-Cal services. As you all know, whatever funds are available for that particular group of people, and as you've seen from the posters up and down the highway, we're allegedly told 50% of the population are now on Medi-Cal. So this is a fact of life. We have to live with it. And we all as physicians, as healthcare organizations, clinics, hospitals and universities have to share that burden. We're not in the position of saying, I won't take this patient. I understand the reasons why many of my colleagues don't take these patients, and they have to do with reasons that I'm sure you're going to come to, including insurance, administrative problems, reimbursement delays, et cetera, et cetera. But I do feel that in the current climate of discussion of universal healthcare, we as physicians should all be obliged to treat a certain percentage of these people, and I include my hat in the ring as a specialist to do that. And I think if more of us did that, we would be able to absorb this burden more equitably throughout our society, and we would make progress.
Yeah, so if I could spring off of that, so Medi-Cal reimbursement rates for providers who see patients on Medi-Cal are low, but they're low across the state. What is it that makes this particular area, hard hit by that particular aspect of this?
So the assumption in that question is that Medi-Cal reimbursement is even across the state, and that's not true. So reimbursement for Medi-Cal within the Central Valley is some of the lowest. And if you look at the state of California, CMS has a website, for example, where they list the Medi-Cal per Medicare reimbursement rate by state. California is 48th in the country. So you couple that with a population that, as Dr. Srivatsa talks about, is 50% Medi-Cal, and you start to see what the economic burden is. And so, a real example is that if you're seeing a Medi-Cal patient in a primary care practice outside an FQ or a rural health clinic, you're getting $16, $18 per visit, when the cost of you to run your clinic is $100 to $150 an hour to cover your overhead. So you can see that there's no way possible for you to see that population without losing money. And so at the end of the day, that keeps a lot of physicians away. Secondly, because those patients have difficulty getting access to primary care and preventive services, when they do come to the physician, they tend to be sicker and more complicated. So it's not just you're getting a low reimbursement rate, but you're also dealing with a patient that frequently has multiple chronic diseases and complexities that you're trying to deal with. So the 50% of the population being Medi-Cal, the reimbursement rates that we deal with in California and specifically within the Central Valley all sort of coupled together to make this the perfect storm.
Yeah, I mean, I would echo that. There are only so many patient slots out there on any given day, and so those folks that are complex pathologically, high acuity patients, are essentially crowdsourcing those slots. They're using more of them than the other person is.
And Jason, being at a federally qualified health center or a group of a family of federally qualified health centers, I mean, how do you feel like Clinica Sierra Vista is able to meet the need of those patients out there on Medi-Cal?
We aren't always able to do that, and I can tell you that. Like many organizations, we're stretched thin with providers, and so, for example, if our one provider at our Easton clinic calls out, chances are we cannot send somebody else out there. That clinic's going to close for the day. So those patients then either have to go to another clinic for care, or they don't get it that day, or for 2 days, or however long that particular provider is out sick or on leave, for example. Couple that with basic issues, socioeconomic things such as transportation, lack thereof. So they may not be even able to get to another clinic for care.
I would echo that. And as I see patients, as you know, the Valley is in an epidemic of diabetes, obesity, and all the concurrent diseases that go with that. And it's paradoxical that you have so many people with so much disease, and yet the resources are not going to the right people. And part of that has to do with the way we organize our healthcare delivery. That's going to be a topic that I almost makes a separate discussion, but I totally echo what you've just heard. And that is when I see a patient who's referred to me, perhaps from Clinica Sierra Vista, they have a multiplicity of problems, and I try to address one of those, the burning question. But of course, as you all know, if you've ever been to the doctor, you always want to have answered 3 or 4 questions. You're not just a one response person. And I happen to be an internist by qualification. So it's very hard for me to say I'm going to close my internist eye and only look through my cardiology eye. I have to treat the patient. And when you have so much burden of disease, it is nobody's fault, but there isn't enough people to take up the slack. One of the other issues is exactly what Jason mentioned, the transportation issue. Many of them don't even have the money to come by themselves to their individual transportation. They're using, some of them, public transportation, many of them government-provided, subsidized transportation. We're moving people all the time to and fro. The whole business needs to be sorted around. The mountain needs to come to Moses, not Moses to the mountain. And one of the ways to do that, I feel, is current technology. We haven't leveraged the telemedicine potentiality that we could. I will tell you quite honestly that 50% of my so-called cardiology follow-ups could very well have been done excellently well over the telemedicine system. I'm telling you that in all truth. And with the kind of technology we have, I really think it's feasible, and we need to try to set up those kinds of systems so that specialists, wherever they are in a pool of availability, can service wherever the need is to the primary care provider. I'm sure UCSF probably is aiming in that direction.
Mm-hmm. And so, when we talk about, right, so we're talking about some specific populations here that, whatever the numbers say, there are different groups of people who are influenced differently. It depends where you live, if you're rural versus urban, what's in your insurance level, your insurance access, your socioeconomic status, things like that. I mean, but when we do come back to, just the actual, the amount of providers that we have here in this area, when we talk about why it's happening that we don't have enough of them, one thing that comes up all the time that probably isn't surprising is that people say it's because it's hard to get people to want to live here in this area. Is that so? I mean, Jason, I'd like to start with you since this is really this is where you're recruiting these providers. I mean, is that accurate? And how much of a challenge is it to get to sort of sell this place to future providers?
It's a yes and no answer. There are some people who have a strong desire to come to California, and if you want to live in California and be somewhere affordable, there's probably no better place than here. So we push a lot of that, kind of spin it to make it a positive. On the other hand, it does have its drawbacks. I mean, I get questioned a lot about, I hear about the bad air, and let's face it, I don't think it's any big secret that for a number of reasons, there are certain stigmas that the San Joaquin Valley carries, specific to Fresno and Bakersfield, that have been out there for years. I can tell you a firsthand story. I had a family medicine doc with me probably a month or two ago, coming out of a residency program in Florida. And one of her classmates, she told me at the end of the day, said, Bakersfield is basically a one burger on a corner stand town. There's nothing there. And by the time she left, her whole perception was changed. And so there is a lot of that out there. People say things that aren't accurate, and it kind of spreads, and until you see it or have been there, your perception is certainly one way. So it's a yes and no question. There are ways to make it positive. Another item is that the climate, for example, when you go to residency, you go where you get in. And so if you've spent 3 years in Detroit and you're used to a warm climate, you want to get out of Detroit at the end of that. And so, there are those that want to come here to escape that. Fortunately, that helps.
So I think I would challenge the presumption that it's significantly more difficult to recruit physicians here than it is elsewhere. It's difficult to recruit physicians anywhere if you're getting them to leave where they finish their training and where they put down some roots. Over the last 15 years that I've been participating in UCSF Fresno, we've added about 130 physicians into the community. And I'd like to say that the most difficult thing is to get them to come and look, and the next most difficult thing is to get them to ever leave. Because they come and they're very pleasantly surprised with what's here. And again, it battles the perception out there about the Central Valley, and we're part of the problem. When I hear that taxi drivers are picking up, my candidates from the airport and telling them what a terrible place Fresno is to live in, I'm saying thank you very much for that help. So I think that we have to face the fact that this is a very nice community in which to live. It's a very affordable community. There's gorgeous countryside around us. It's a city with lots of resources, so that we have to be in a position where we're out selling this. That being said, too, I think that there are two best predictors about where a physician is going to end up practicing. And those predictors are, where did they grow up? And so the first challenge that we have is that kids growing up in this region do not go to medical school at the same rate that they do in many other parts of the country. So we have a smaller pool to draw from there. The second most important predictor is, where do they finish their training? Not where they start their training, but where they finish their training. And our own experience is pretty much what we see around the rest of the country, or reported in the rest of the country, that if we look at our graduates coming out of our program, 50% of them are staying in the region. And the best places that have medical schools all the way through residencies and fellowships will retain about 70%. So, and we tend to be, again, very under-resourced in terms of the number of residency positions and fellowship positions per population than the rest of the state and the rest of the country. So we're fighting a little bit of an uphill battle because the pool we have to draw from is smaller, so we have to be better at it, but we also fight the problem that we need to be our best proponents, not opponents, in this process.
And, what else, I mean, how I mean, this idea that this may not be a desirable place, or that people believe that this may not be a desirable place to live. I mean, how does that, I think when I first heard that, I kind of, I may have scoffed at it and said, well, that can't really be that big a deal, really. I mean, how does that compare to these other limitations? I mean, Dr. Srivatsa, you mentioned, we're not maybe fully taking advantage of telemedicine here. Perhaps that's a drawback to certain providers. The high Medi-Cal rates. Yeah, what is the role of this kind of desirability of location?
I think, as far as we'll take the question in two parts. First of all, I spent a good deal of time around London, England. I then spent vast amount of time in Rochester, Minnesota. So that's a pretty cold place. And when I went there, it was pretty desolated. But believe me, I wouldn't have left it if it wasn't for some other issues in terms of my immigration status. I would have stayed there and been part of the buildings. So it isn't always what you think about, and here I am in Fresno. And by the way, my son, who wants to go to medical school, wants to do so here in California and possibly right very close to where we are. So a lot of things draw people. I'm with Dr. Peterson in the question of where people stay. If you have roots in this area, if you finish your training here, probably you'll give this a very strong consideration. But let's go back to telemedicine. Telemedicine is something that has been embraced by dermatologists and psychiatrists, but not really to any great degree by my profession. And it's very unfortunate because, as I always tell people, there are only 5 symptoms in cardiology, and the rest of it is down to proper examination and diagnosis. Now, we can do all that. There's really no reason to drag Jason's patients from his clinics from all over the countryside to me when I can make a diagnosis and a very intelligent treatment plan right from where I'm sitting. And that has been proven time and again by studies. It's not just my inkling. And until we start to do that, until we pool our resources in terms of specialist care and share that amongst primary care in some sort of meaningful fashion, that we won't be able to do it. And one of the reasons we can't do it is because when you look at the way Medi-Cal is structured, once you get past the division of monies to the first level, let's say the HealthNet, HealthCal, HealthNet, Medi-Cal, and all the other large providers like Anthem Blue Cross, they subcontract their care down. And once you finish subcontracting, you don't know where you stand as a specialist. You might be available to another organization and be perfectly qualified to provide care, but you're not contracted with them. And then there's bureaucracy as to what you can or can't do for one organization or the other. This is one of the reasons why people have made the case for universal health care. And when 50% of the population is on Medi-Cal, maybe we need a universal Medi-Cal care. I know. Then, of course, there are those who say, it's just way too expensive, we can't do that. But right now, what we have is a half-eaten bone being passed down the line, and the patient is just left with a marrow. And we just need to figure out how better to do that, because I personally believe, as has been stated by different politicians, and I think most people feel, education, healthcare, the right to breathe clean air and good water and nutrition. If we can't take care of that and the right to free speech, what do we have as a nation?
Dr. Srivatsa, when we've spoken in the past, another reason that you've mentioned as perhaps playing into this idea of lack of access for certain groups of people, you mentioned something about another division that we have in the medical field is doctors groups, and you yourself are in a private practice. So I'm curious as to why you chose that and how you feel like that impacts your ability to access patients versus if you were in a doctor's group.
I think there are advantages to doing it both ways. I'm of a particular era where I'm perhaps at the tail end of it, where we focused on individual private practice in small groups or as individual people. I have to tell you, I'm a dying breed. It's all going to be organized through larger care organizations, and it's probably for the best. Providing that the healthcare of Californians, particularly our Central Valley citizens, are actually improved meaningfully. Unless we see an ability to verify that that's happening, I can't say that one group is particularly better than the other. But when you look and you see perhaps as Michael's group is organized, they have brought together multi-levels of care, from primary care to specialists to teaching. Why is it that we can't reproduce that model, yes, even as groups of people across California? We can't all be a teaching center, I appreciate that. We can't all be a Kaiser Permanente, but there has to be a way in which those interested in providing care to this group of people are brought together in a meaningful and efficient way. And there's one other thing I will say. I think for people to say they won't take these patients because of poor payment, delayed payment, administrative costs, I can just carry on listing down the line, is okay. It needs to be addressed, but we all need to share the burden of society. It's just like taxation for healthcare. We can't just skip out on it and say, I won't pay, you pay. So I think as a physician, as a specialist, we should all be required to take on a certain percentage of these patients and provide the best care we can.
And when we talk about the financial incentives or disincentives of being in this area, I've heard different things from different doctors in different organizations here about salary level. And of course, it does vary. But are there financial incentives for doctors to be here and providers to be here in this area? I mean, the cost of living is quite low, but how are they compensated compared to other parts of California?
I mean, I think on average, we're competitive. The cost of living is so much greater in some areas. I mean, that truly, helps us. These folks are getting out with a pretty heavy debt in many cases. There are some other designations, for example. Folks can come here through like National Health Service Corps and have their student loans, paid off over time for working and being here, which is a great thing. Again, that kind of thing helps.
That's specifically with federally qualified health centers, correct?
Absolutely, yeah.
So within our own, within the UCSF system, actually our faculty are relatively well paid here compared with the faculty that are in San Francisco and live at a third of the cost of living. So I don't think that's really a driving force about why people come or don't come.
I would agree with that. I think if you look at the published data I'm speaking only about specialists because I'm wearing my specialist hat today. You will find, as you know, there are all of these reports that you can look up in the Wall Street Journal. I have to tell you, there are some people in my trade who lead the entire country in their remuneration. So it isn't just true that it is that there isn't enough money in the game. I think the bigger question is not whether we pay the doctors enough, but whether as a society we are putting enough into healthcare, and whether that on a state level is being directed to the people who need it and not being lost with the subcontractions which are going on in our society right now is the way we structure this Medi-Cal business.
Okay, so now let's talk a little bit about ways in which we may actually be able to approach solving or mitigating this problem. We've already touched upon a number of these things, which we'll come back to. But I want to start with training. There's been a lot of talk of medical schools locally. UC Merced has been threatening a medical school for a couple of decades. California Health Sciences University plans to open an osteopathic medical school starting in 2019. Assemblymember Rambula just introduced a bill to bring a med school to Fresno State. So Dr. Peterson, you've also mentioned that you think it's really the fellowships and residencies that maybe make a difference. Tell me a little bit about that. I mean, would a medical school or medical schools help put a dent in this problem?
So the answer is fairly complex, but the short answer is that the narrow part of the funnel is the people who graduate out of graduate medical education programs, not the students that graduate from medical schools. And without an expansion of those positions, that is the GME positions, simply you'll be displacing current candidates within those residency programs with candidates potentially coming from medical schools here. So I really think it has to be viewed as if you're increasing the medical students that you're putting out, you've got to couple that with increasing the graduate medical education opportunities in residencies and fellowships. Otherwise, you just frustrate the system, and at the end of the day, you don't get any more doctors into the system. And what we know from many experiments, including one in California, is that when you train the medical student in one site and they go away to do their graduate education training somewhere else, they do not come back. So the experiment in the UC system was UC Riverside. So 43 years ago, UC Riverside was established as a 2-year school where the students then went to UCLA to finish their clinical training with the expectation they would come back to the Inland Empire. And what they discovered over those 43 years was those students went to the same places that the other graduates of UCLA did, and they did not come back to the Inland Empire. And so that was part of the argument for expanding UC Riverside to a 4-year school. But coupled with that, They have been spending a lot of time and effort over the last 5 years building new residency programs so that they could keep those students into the residency program, understanding that that's the way that you retain those students then in your region.
Yeah, so, to give you an idea, and I completely agree with that, it's great to produce MDs, but if we don't have the residency slots to accommodate those, it's going to be troublesome. Currently, because those residency slots are funded by Medicare, those rates continue to stay at the levels they were since 1996. If that gives you any idea, they have not changed, they have not increased. So we've gone a very long time without increasing any of that.
Yeah, that speaks to the issue of medical schools. But there is, of course, a parallel process going on, which is to increase the number of mid-level providers. And as you know, a Rambolas bill doesn't just argue for the medical school. It also talks about expanding the mid-level providers and their training campuses. I agree with that, that we have to have some mid-level base on which to provide this care. But like everything else, it has to be directed, it has to be supervised, and there has to be somebody who accepts overall medical responsibility for the direction of this patient. And therein lies, again, back to the thrust of the problem, where are we going to get that person? So it is okay to do these things, nurse practitioners, physician assistants, we need them. There's even talk about using pharmacists in some adjunctive role. But at the end of the day, who will accept care for the patient? And once the complexity of the problem exceeds that of the primary care provider, who will then accept this patient and take care of this patient to the point that they can go back to the provider? We need to answer those questions too.
Yeah, I'd like to talk about mid-level providers in a couple moments, but I want to stay on residency programs a little bit. I mean, what are the challenges to getting more residency programs here? How do we get more of those here in this area?
Money, money, and money. So as was mentioned, the Balanced Budget Act of 1997 established a cap on the number of residency programs. So if you're a hospital with residency programs at that point in time, you established a cap. No further federal funds would come to fund additional residency positions, and to this day, for example, Community Medical Centers has a cap of 120 plus or minus, and that's it. There is no more funding available for those positions. And then if you establish new residency programs, you really have to be ready to come out of the box, ready to go, because they allow you 5 years to establish your new cap. So you can't slowly and progressively build the residency program, because very quickly you'll be at your cap, and from that point on you're funding those positions with your own revenues coming out of the hospital. Now there have been a number of attempts to look at, all right, if the federal government is not going to be the solution to this, what are alternatives that are available? And that's why HRSA's funding of the federally qualified health center teaching centers was an important step towards increasing the number of training slots that were available for primary care positions. But unfortunately, those dollars can be taken away at any time. The budget goes down, they decide that they're going to cut that funding, and you're stuck with how you're going to pay for your residents. Many states, probably New York being the best example, has taken that role on and said, well, then the state should step up and fund some of these positions. And there are at least 2 programs potentially within the state of California that could help to do some of that. One is the Song Brown program that sunset but is being considered in the budget but not being significantly supported by the governor at this point in time, which would put $100 million into residency positions within primary care, that being family medicine, internal medicine, pediatrics, and OBGYN, with about a third of those dollars designated for new programs. Secondly, many of you may have voted on the tobacco tax proposition that was last November, and that tobacco tax proposition was to have dollars into it that would go to the University of California, and that was about $40 million a year to establish funding for, again, the expansion of and development of new residency programs in primary care. Both Song Brown and the tobacco tax dollars were to be designated toward areas of the state that had the greatest physician shortages. And no matter where how you look at whatever manpower studies have been done over the last 15 or 20 years, that's the Inland Empire and the Central Valley. Both of those, the governor, at least initially, moved those, he provided those dollars to the UC, but then cut the UC budget by $50 million. He's now apparently put the $50 million back, so there may be dollars to do that through that program, but that's still working through the legislative process. So far as I know, there's been no final decision on the Song Brown $100 million, and that's working its way through the legislature too. So it really does come down to how do you fund these positions. Just so you get an idea, so a resident coming into a program, they get paid about $55,000 a year, and we can only work them 80 hours a week. Sounds like a bargain to me. From a standpoint of what you get for your dollars, it's a tremendous benefit. Plus, you get people that are then going to go into practice in your community. But this state has not yet been willing to make the kind of investment it needs to address these issues.
All right, well, so then let's talk a little bit about the structure of the healthcare system itself. I mean, right now, we're pretty doctor-centric. Maybe is one way to interpret it. You know, patients are giving appointments, you know, one at a time to see the doctors, never works for them. You know, what are some ways that structurally that could change in how we actually deliver healthcare to patients?
Well, it's very fragmented. I mean, this is probably one of the most fragmented industries there is. You know, we aren't as efficient as we could be. There's not a lot of consistency across systems and you know, organizations, disruptive workflows and that kind of thing. You know, there's a famous business story about Southwest Airlines, and you know, it's no secret why Southwest Airlines flies a fleet of 737s, and that's because it's efficient. You know, everybody in that organization knows that plane inside and out, and so you know, their model of efficiency is that when a person you know, plane is pulled off and they have to bring in another one, that every crew member knows that plane inside and out. And that's how healthcare should be. I mean, we should be looking for those commonalities and approaching it. And I think in that kind of vision, you know, what can we do better? What can we do quicker? EMR platforms, you know, electronic medical records, you know, none of them talk to each other currently, I mean, or rarely. It's very fragmented, and that definitely creates bottlenecks.
So I think that you touched on mid-levels, and Dr. Srivatsa mentioned clinical pharmacists and so on. So I think that one of the things over my career, medicine has changed, and we have moved from where we took care of patients who had an acute illness and then things moved on. We've gotten very good at taking care of things like Dr. Srivatsa's colleagues in acute myocardial infarction, and those patients that are now living a long time, but they're now living a long time with a chronic disease. They have heart failure, we have patients with COPD, we have patients with diabetes, so that a lot of the patients that we now take care of, and on the adult primary care side, it's estimated 75% of the patients that a primary care adult specialist will see are patients that they're managing for 1, 2, 3, 4, 5 chronic diseases. And what we need to do is to learn how to work smarter in a team-based approach to that kind of care, so that, yes, could a doctor do all of those things? Yes, but is that the best use of the talents of a physician when there are other providers that could do a similar job, a clinical pharmacist dealing with the drug management of the problem and teaching the appropriate dosing and so on, a nurse practitioner, a social worker, and let the physician do what the physician does best. So that if you look in a general practice, maybe a primary care doctor carries a panel of 1,500 patients. Well, if you put together a team around that doctor to help take care of those patients, maybe they could be taking care of 3,000 patients. And now, with the same number of patients, with the same number of physicians, we've now amplified the impact of those physicians. So I think as we look at things like patient-centered medical homes, neighborhoods, patient care neighborhoods, that this is really a model that we have to be looking at very seriously about how we provide care.
Yeah, when you look at the budget, what goes out in terms of monies for Medicaid in California, you see very much that the people with the disabilities in the long-term care facilities take up 50% of the budget. And unless you're able to take care of these patients in a more efficient way, and speaking of patient-centered medical homes, telemedicine, this kind of thing, unless we embrace that, unless we structure our care around that, and we have the ability to talk across organizations and across insurance providers, across third-party payers, I don't see how we can do this. I can show you patients with the same diagnosis, the same request for the same procedure, which is denied from one organization and accepted from the other. Two people from the same organization where two different drugs are accepted, one as covered and the other is not covered. You have no idea of the nightmare of complexity in getting medications or procedures approved. I personally have staff just dealing with that all day long. The patients experience frustration. They think that the doctor's procrastinating. You just don't understand how bad the system is, how the bureaucratic entanglements leave us tied with both hands. And it isn't just a matter of payment. If you look at the frustrations of providers dealing with Medi-Cal patients, they will tell you it's the complexity of patients, it's the constant bureaucracy, the constant inability to tell what is the game plan, where are these goalposts? Are they constantly moving? Where do I kick this ball? We have to address that. And unless we address that, and we address it for people, not just the people in the clinics, but the people in the long-term care, nursing homes, disabilities, these people are the biggest burden. And as we go into this new era of our new American Health Care Act, I'm sorry to tell you, I'm not sure that the security of these people is there or secured for the future. I have grave concerns for that.
Well, and we've spoken about the roles of physician's assistants and nurse practitioners. What about pharmacists?
I mean, specifically them, but all of those. I mean, the rules could certainly be expanded. And I think there's small steps in that direction. I mean, we've seen some movement of the needle of the scope that RNs can do, for example, and NPs, here in recent years. And that's a good thing. That's a good step in the right direction. But I think there's a long way to go, and that would be helpful. If the reins were let up on them a little bit as far as what they can see, treat, their scope of care, practice.
So I've been fortunate in my career to work with a lot of really high quality clinical pharmacists. And so I've come to appreciate what they can bring to the table in terms of patient care. So I think that is really an untapped resource that we can bring into the mix of managing these patients. Again, if you look at poor outcomes in patients that you're managing for chronic diseases, much of it is related to the fact that the patient didn't understand how to take the medicines, they weren't taking the medicines correctly, that if you could just help them to understand what they need to be doing for themselves, your outcomes would be better. And is that the best use of a physician's time? Probably not. But is that a great role for a clinical pharmacist? That's absolutely a great role for a clinical pharmacist, and to help those patients in terms of learning self-management, how they adjust their diabetes medicines, all of those kinds of things. So I think that there are lots of opportunities for us to have everybody operating at the top of their license, as we say, so that everybody's optimally contributing to the patient care.
Yeah, I think that's one of the sources of frustration for most patients. I think if you've ever been a patient in a clinic with more than 10 medicines, you understand. I tell all my patients, put all your medicines in a plastic bag and bring them along. And then we have a 5-minute conversation in which I say, omeprazole is for acidity. Aspirin is for heart prevention. Metoprolol might be for this. Such and such is for this. And there's like a big glow of recognition at the end of that. Oh, that's why I take this medicine? And it's like nothing else after that matters in the conversation. So if I could have someone who could do that for me and do it intelligently and in coordination with me, why not? Why not embrace it?
And so, we've talked a lot about many things that perhaps could improve patient access and mitigate the effects of this doctor shortage. I mean, improved access to telemedicine and technology, better leveraging, so-called mid-level providers and pharmacists. And there are places that are doing this on a clinic or health center-wide scale. I mean, how does something like this get implemented on a community scale in a place as huge and varied as the Central Valley?
One of the things that now we're exploring the future, so to speak, which is nice. will assume that the budget is endless and that the Affordable Care Act is still out there and thriving, and that everybody has a multimedia Obamacare phone. Now we might be in business. I'll tell you why. I think the biggest technological revolution is the cell phone. You will find that people, even of limited income, will go to the nth degree to possess one of those. And I actually think it's a great thing. How many ways can you think of that can immediately reach a patient and remind him of an appointment to take a medicine or something immediate, as in, do not take your Coumadin today, your INR is too high. By the way, that's just a medical example of a blood thinner and a test. But there is also a bigger opportunity, and one which private companies are now trying to tap. For example, one of the biggest public problems that we have in the Valley is diabetes. Yes, we all know this. You come into the clinic and the doctor says, well, what are your blood sugars running? And then they scratch their head and said, when? Last week? Today? What's the trend? Well, I can tell you, but my husband's got the machine. We need to have something where this data, whether it's blood pressure, whether it's weight, whether it's pre-meal glucoses, these kind of things are they're simple data. None of us should be practicing blood pressure control on one reading in the office. We all know that. But what choice do we have? That's the only reading we get. Who's going to give us another reading? And that's when you consider that a blood pressure machine is available for $30. Probably could be connected to the internet. A lot cheaper than, some of the other things we splurge our money on. So the cell phone, the internet, the patient-centered home, and ability to do. And by the way, it isn't just for the care of patients, it's also for the teaching of residents. I will tell you that every single day I see superb signs that I'd like to, or symptoms that I'd like to show to a young developing doctor. How's he going to know that unless he's apprenticed to me at that moment in time? And instead of doing that, if I was able to record those things and upload them to a database where they could share in real time. We never had, in my generation, we had textbooks. You thumb through the textbook, you saw the worst case of the disease possible, and then you extrapolated. Now you have the opportunity to see in real time and imagine that you're a fly on the wall of any kind of educated physician. Why don't we leverage that?
Okay, well, I think we should probably move on to audience questions shortly, but I wanted to end on one last thought. I mean, if we, it's the magic wand question, if there were one thing that could either improve the number of doctors or providers, I should say, or improve access to them, what would be the one thing that you would really prioritize over anything else? Let's start with you, Dr. Peterson.
Oh, thanks. I think that one of the areas within the ACA which doesn't get sufficient attention, which is early on and which I think has the potential to be a game changer, is the issue about population management and having a shared risk model where your job as a physician is not to do tasks and bill for those tasks, but to look at patient outcomes, health outcomes, and that your reimbursement is tied to that. And then you can decide how you align the resources to address those patient outcomes. So I think that we have bizarre incentives built into our system that pays physicians for what they do and not what they think or how their outcomes are. And so I think if there's one thing that we could do is to move that model forward in terms of a reimbursement model for healthcare, that it would actually have a positive impact on health outcomes and access.
I will take a zoom out on that. I agree with that, by the way. But I would suggest that we need to rethink about the way we organize care for the underinsured and uninsured. And we need to scrap the system and start again. If we're discussing in theoretical potentialities, we have, as you've just pointed out, a governor who's quite clear that he wants a bill passed where he wants the money spent on the roads and on certain taxes, and he's quite clear where that money is going to go. We're not so clear about where our tax money is going in terms of healthcare. And by the time it's divvied up and by the time it's subcontracted out, we have no idea on the efficiency of that care. And it would be very nice to know what outcomes are, but who is going to coordinate that? And where is all that data going to be collected? We have a little bit of it. If you go to Oshpot and you want to look around there, you have some clues as to the major things driving. But we need to reorganize the way care is provided. It needs to be centralized, at least for the uninsured and the underinsured, and somebody needs to be responsible for it. My opinion is the way the health insurance industry is structured is a disaster and is counterproductive to the way in which we will provide care to the underinsured in this state.
So I think two things, kind of going back to what we talked about earlier, increasing the pipeline, at all levels, more medical schools, more residency slots. I think also second part of that is dealing with the dysfunction that these two gentlemen have mentioned here. There's a lot of studies out there that the vast majority of current practicing physicians would not recommend that their children go into medicine, and that's an unfortunate thing. And I think that speaks to a lot of the system and how broken it is, and how much disarray there is. So we're not even promoting it, the right way to our own kids and so forth, and that's too bad.
Okay, all right. Well, I feel like, I almost feel like I need to follow that up, kind of like the end of Wait, Don't Tell Me. Well, if any of those things happen, we will ask our panelists about it right here on Valley Public Radio. No, but really we will. So I think we would like to open this up to audience questions now. So we have that microphone right over there. If anybody has something like they would like to ask, you can just go step right out to that.
Or just speak up.
I might be able to talk loud enough.
Kerry, does that work, do you think?
No, they should be on the microphone. Because it's being recorded.
We were so thorough, nobody has a question.
Thank you, and thank you for this excellent panel. I learned so much. But one thing I didn't hear, and I feel very strongly about, and I was on a couple of medical boards, and you might be familiar, Doctor, since you were in the Midwest, with the Allied Health Consortium in La Crosse, Wisconsin, and the community, the role of the community in its conceptualization of each citizen's view of their own health. The patient and their responsibility has not been mentioned yet. And to me, and then that leads to prevention. In other words, you doctors wouldn't have as much to do if people took more responsibility for their own health, and if communities offered more educational programs for, what to eat, how much exercise to get. Anyone can learn these things. And then the second thing, and I'd like to hear you address that because you probably have ideas, and the second area is every single human endeavor of our society is in a constant uproar and change right now. I remember the old medical model of omnipotence. You wouldn't think of questioning your physician. In fact, if it weren't that there
It's changed?
and one that wasn't like that actually saved my life. But anyway, this notion of how we conceptualize the whole medical model with these new partnerships of community, of insurance problems, of da-da-da-da-da. And it takes, to me, a community dialogue, and this is why this is so important, and I hope Valley Public Radio really gets it out there. So would you respond to those three things?
So I think in answer to your, or to at least address, I don't know if I can answer your first question, but to at least address your first question. So human behavioral change is incredibly challenging. And I think that as physicians, we don't really have as much education or support with that, and we need to learn from our colleagues in the social sciences about some of those things, because I think it's at the root of a lot of what goes on. In addition, we're a very biologically based specialty or profession, and it's really taken a while for the social determinants of disease, the issues about nutrition, exercise, poverty, all of those kinds of things, be translated into the biology to suddenly the light bulb goes on and you realize, oh my goodness, this really has an impact on the basic biology of human beings. And so I think you're seeing a lot more attention from the medical community on those kinds of things and addressing behavioral change. To follow on what Dr. Srivatsa was talking about is to harness technology in a way that helps to drive human behavior and patient behavior. So how many people in this room have a Fitbit, or they have an Apple Watch, or they look at their cell phone and count their steps every day? And if you don't think that changes your behavior, you're wrong. It changes your behavior. So being able to have things, for example, Silicon Valley is coming out now with potential diabetes monitors that can measure your glucose through your skin. So no need to prick your finger or draw blood, and that could read right into your cell phone, and then you've got a record of what's going on, and not only to show your doctor, but now you have a target for what's going on in your own body. So I think that there's lots of opportunities for us to take that on. I also feel it's really important that that the patients understand that it's a partnership with the physician. That this idea, as you said, the old model of an omnipotent physician, you go in, I tell you what to do, you go home and you do it, is no longer the model. And really what it needs to be is I can give you best advice, we can talk about it, we can negotiate it, but at the end of the day, you're the one that has to go home and make the changes that need to be made. My job is to try and understand how to motivate you to do that.
I would say, which is interesting, I agree with that. What I see in the underinsured and uninsured people is that we have to recognize several different demographics here. If you look around the Central Valley, we are more than 50% non-Caucasian. We have people from different races, multiple languages, different levels of education. There's an old saying that, you can only bring democracy to a group of people once their stomachs are fed. If not, they're going to be corrupt to any form of government that actually feeds their stomach. I find when I see patients that I spend 2 minutes making the diagnosis and the other 20 trying to explain either the drugs or why we're doing what we're doing. And I'm not doing it with fancy pamphlets. I'm trying to explain to them that when you put on too much weight, that you challenge the pancreas and you develop a condition called type 2 diabetes, and that you actually shed this weight, you might find yourself not taking any pills or anything else for diabetes. That's such a profound revelation to some of these people, because they don't speak English, they don't read the same books you do, they don't watch the same television programs, and they don't understand any of this. And you know who's doing that in the room with me? I happen to have a medical assistant, we're fully bilingual, that's neither here nor there, but it's the young child of the patient who's doing the translation. So that got me thinking, is that what we actually should be doing is to training the kids of this generation to go back and tell them why they should be eating or exercising or doing anything else. Because believe me, if your child tells you you're feeding him poison, you won't do it the next day. There's a lot of that. And we need to harness the schools. We need to harness these children in middle and high school so that they change the patterns of behavior that you're programmed to doing through your parental generation's training, because that's the best they knew. That is particularly true of our minority and ethnic populations. We need to address that head on.
Okay, I think that we have time for, probably this will be our last question. We have someone standing at the microphone. Go for it.
I actually want to make a counter argument to human behavior. For someone who worked with public health for 13 years at my previous job in Kern County, so Bakersfield, there are incredible programs out there. For example, the promotora model. And promotora is not just in the Latino community, but of all ethnicities, who go out there and educate from car seats to obesity to folic acid deficiency and neural tube defects. Number two, there are programs such as WIC, federally funded, SNAP-Ed, which is food stamps, that do a lot of education. Number three, the way a community is built and designed impacts your health. So it's just not human behavior and willpower. It is the communities you built and designed. Let me give you a really great example, because I did this for a living in land use design. When I live or work right here, 168 in Herndon, I have access to a Save Mart, I have access to a Vons, I have access to a Walmart, and I have access to safe, walkable streets. Come and drive with me to Jensen and 99. There is the highest concentration of fast food restaurants. I don't know where the safest park is with clean, accessible drinking water. And I have no idea where the major grocery store is for West Fresno. I worked with land use and planning to say don't zone another fast food. When you geomap chronic disease rates, the highest rates of diabetes, the highest rates of, what am I working on right now? Blood pressure, the highest rates of any chronic diseases are overlaid at the highest levels of fast food, lowest green space, less access. So a dialogue should be really with our city planners. How you build your future cities impacts the health. I want to get your patients off of blood pressure medicine, but I want my patient in Carruthers to have access to bonds at a lower price. But if they have to drive to Selma, which is a 40-minute drive for them, or where I was in Lost Hills where I work committees, or had to go to Delano, which is a 45-minute drive just to go to Vallarta once a week, I can't win. And who helped with that was Paramount Farms, because Paramount Farms is one of the major ags in Delano, and they built clinics at their sites. And they built clinics for anybody on their facilities to use. They control their insurance rates. They reduced the number of sick days, because who wants any employee out? And then they got their families to say, if you're sick, come and use our clinic. So the discussion is also with Big Ag. I know I took time, so sorry. Thank you.
No, it's time. As luck would have it, I actually spent the day at Lost Hills today. And they have done amazing things in that community. And it gets at the issue of it really is a community that has to come together to address those issues. So yeah, I agree with virtually everything you said.
All right, well, wonderful. I think it seems like there's more that we could talk about, more questions. Then we're going to have to end this here, but I invite everybody to come and enjoy more of these refreshments over in our conference room, over just on the other side of the main entrance where you all walked in. Chat with each other. Perhaps our panelists can stay for a few moments. Yeah, please join me in giving our three panelists a very sincere thank you for being here tonight.